So we just wait for another minute to allow people to come in the virtual room. Numbers are already going up. Very good.
Yeah.
So let's wait another 30 seconds. Okay, I think we can start. Numbers of participants are stagnating coming in. So good evening or good morning, wherever in the world you are, and welcome to this ENS spine section webinar of the month of October now. I'm very happy to have as guest today Dominik Rotenfluh. Dominik Rotenfluh is from Switzerland. He's an orthopedic surgeon, was trained in Switzerland before he spent many years in Oxford, UK, 10 years, and has a lot of expertise in very complex spine surgery, whether it's tumors or deformities. Is a very experienced spine surgeon doing spine surgery only. He's the newly appointed full professor and chairman of the Department of Spine Surgery at the University of Lausanne. So he just returned to Switzerland, to his home country. He's a close friend of the ENS. He's active in many courses, since many years active in the ENS advanced spine courses and in the training courses as well. So there's a quite close relationship between Dominik and the ENS. And this is even more important now as you're the education chairman of Eurospine. So I'm happy to have you here tonight. And we have a special topic, rare pathologies, but important to know these pathologies, to know the algorithm in the workup of these pathologies is primary spinal tumors. And Dominik's going to share his expertise in the treatment of those primary spinal tumors and the surgical treatment of these tumors. Dominik, welcome, and we're happy to hear your presentation.
Thank you very much, Florian, and especially thank you very much for the kind introduction and the invitation. As you were saying, I think ENS, myself, and Eurospine are good friends, becoming more and more and collaborating more and more. And certainly when you asked me whether I'm available for this webinar, I didn't hesitate to confirm. So as you were saying, I was working for 10 years in the UK, and most of it in Oxford, and just recently moved back to Switzerland a few months ago, and I'm now heading the spine center at the University Hospital in Lausanne. But most of that work that I'm going to present, or pretty much all of it, has actually been done in Oxford. So that's why I'm changing the slide color still. And I would especially like to acknowledge the team in Oxford and my esteemed colleague Jeremy Reynolds, with whom I've been fortunate to work over all these years. And we essentially, when I joined Oxford, he'd already started the tumor practice, and I basically just walked in and joined him there. And then over all these years, we did it as a essentially team of two, doing these sometimes challenging and lengthy surgeries. So some of this talk is essentially about our experience, some of the cases that we've done together that will illustrate some of the points that I'd like to make, and then we'll have time for discussion. So primary tumors of the spine is really a rare pathology. You know, we deal with about 1 to 2 million cases, 1 to 2 cases per million population. That means that in the UK we had a reasonable caseload, especially serving a larger population and for primary tumors. Whereas in Switzerland, that's now with a smaller population, those cases are going to be even more rare. And that's relevant because they're challenging surgeries, they're resource intense, and requires a team, in my view, a team in a large medical center to treat most of these cases, especially the cases I'm going to show you in a proper way. There is a debate, and we'll touch upon this, whether anything appropriate resection is really possible, what that actually means, what does it mean to do anything appropriate resection or resection when we have clear margins. And it's very clear in most of these cases, we just have one chance to actually get it right and change the outcome and the further course of the patient. Those are the usual suspects in tumors that we deal with. They're benign and malignant tumors. On the right, you see data from the AO Spine Tumor Knowledge Forum. My colleague Jeremy Reynolds is a member of that, and those are the cases that are in registry, kind of showcasing how frequent each type of tumor is. Clearly, chondrosarcoma and Ewing's and osteosarcoma are the most frequent malignant ones, with schwannoma, which we as orthopedic surgeons normally do not treat, osteoblastoma, hemangioma, aneurysmal bone cyst, and giant cell tumors being the more frequent ones in the benign section. So what are the indications for en bloc resection? Well, those are generally malignant tumors that are low or high grade, that have not metastasized, and that are amenable to en bloc resection, which I'll illustrate what that actually means. But it can also be aggressive benign tumors that are locally invasive, that may require or lend themselves to en bloc resection. And the word benign tumor is kind of a relative term. A benign tumor is probably only really benign if it is latent or not necessarily active. But when a benign tumor becomes locally invasive, can be aggressive, then it may not actually, then it does not metastasize, but locally may not be benign. It may require further surgery, revision surgeries, and have a tremendous impact and morbidity on the patient. So some of these cases are then so benign after all. The goal for en bloc resection of primary spinal tumors is the most important one is really to gain low tumor control and thereby reduce the rate of local recurrence. We would like to prevent the tumor metastasis by resecting the tumor en bloc, so that means with clear margins, and this should at the end of the day then also improve survival, and depending on the tumor biology, that is not always necessarily so, and it may need additional adjuvant treatment. Separating the tumor capsule, and that's an ongoing discussion really, whether if a tumor has invaded the spinal canal, whether it's still resectable en bloc, but actually separating the tumor capsule from the dura and the canal is not associated with the same rate of local recurrence that we would get if we did an intralesional resection. That means if we breach the capsule and do not have clear margins anymore. So what are the resection margins that we're looking at? Well, if this is the tumor, I hope you can see my mouse here. So if this is a tumor, whenever we breach the tumor, then we are intralesional. If we just correct it out, then it is an intralesional resection with essentially no surgical margin. If we go along the tumor capsule, which is what we in most cases do, then it is a marginal resection. And if we are in healthy tissue, then it is a wide surgical margin. Now, being within healthy tissue is actually rarely possible in the spine, essentially with the tumors that we've seen. If they come and are a bit more in an advanced stage, then they're not confined to a single compartment anymore. If they're not confined to a single compartment anymore, we do not have a wide surgical margin, or what in general surgery they would call an R0 resection. Then we deal with a marginal surgical resection. And even though we can go wide in a larger area, as soon as we actually get to that tumor capsule, it is not a wide resection anymore. We already deal with the marginal surgical marginal resection. If we breach the tumor capsule at some point, then we're already intralesional, even though we took great care to preserve, for example, the tumor capsule or get a wide margin anywhere else. That's a bit peculiar to the spine, and that we cannot get these wide margins as one would normally expect. So wide margins we can really only get if we're intracompartmental. This is a classification by Tomita et al. If it is, for example, just confined to the vertebral body, then we can do the typical resection that, and I'm going to show the classic technique by Tomita, where we transect the pedicles, take the lamina, and then do a spondylectomy. There we're not going to breach the tumor, and we're actually going to have wide margins. Most tumors that we've seen and the examples that I'm going to show you were actually in here in the middle. They were extracompartmental, so they've breached the bony compartment, they've breached into the spinal canal and sometimes compressed the cord. And obviously the ones that are then have multiple sites of tumors there, they already have local metastases, are not in continuity. Those are not en bloc resectable. We would not consider en bloc resection in those type of cases. So the original work by Tomita has shown, and that's some of his series, that compared to palliative decompression, just debulking, which essentially is an intralesional resection, or en bloc excision, the survival here was clearly better if we can compare en bloc excision for the primary tumor compared to debulking, or even just the palliative decompression, which is the line very at the bottom here, indicating that it really matters how we resect those type of tumors. That's early data from Boriani, published about 20 years ago with chordoma and chondrosarcoma patients, and show that that only a minor portion of patients have recurrences if they are resected en bloc, as opposed to 100% local recurrence if we do an intralesional resection or if we breach the tumor. Then we now have a bit better data. We're in the era of registries and study groups, and this is the data from the Spine Tumor Knowledge Forum here on 166 cases of patients of chordoma of the mobile spine, which shows that they clearly they significantly reduced the rate of local recurrence if we consider Enneking appropriate versus Enneking inappropriate. Now, what does that mean? Enneking appropriate here would mean that we have clear tumor margins. If it is Enneking inappropriate, then we do not have clear tumor margins. So that means even a marginal resection that has an intact pseudocapsule across the tumor, the pathologist comes back and says there were clear tumor margins, those would be considered to be Enneking appropriate. Whereas it does not have as much of an effect on the survival of the patient, funny enough. Even all these years after or in a shorter period of time after surgery, that is not like long term, like 20 years down the line. So statistical analysis did not show any significance there, but it has a clear effect on the local recurrence rate. And a similar picture we see here with sacral chordoma, where the local recurrence rate, even after en bloc resection, is a bit higher. And Florian and I we have been working on a systematic review looking into this and also comparing it to the role of radiotherapy in these patients. And what I've highlighted here in red and is really, that's really the difference between the Enneking appropriate and inappropriate. So whether we have clear tumor margins or not clear tumor margins. So if we consider that in the future, radiotherapy, proton or carbon therapy may be the way to go with an intralesional debulking of the tumor, then the radiotherapy has to be able to take care of that delta between Enneking appropriate and inappropriate resection. So essentially the red space in the chart. So there are many studies that have already shown the safety and that there is a role for radiation therapy, particularly more modern radiation therapy such as proton or carbon therapy, in order to get local tumor control. The questions that remain: is it really as effective in local tumor control? If we then irradiate a younger patient with proton or carbon therapy, then we get a lot of scarring around the tumor, around that site. That certainly makes surgery a lot more difficult than it would have initially been. The question there is, is surgery in terms of unblocked resection with clear margins then still possible after that radiation therapy? In some cases, it may not be if the tumor touches upon vasculature, for example, which then would have to be resected together with it. Then it all of a sudden becomes a risk-benefit analysis whether unblocked resection is still possible. Current recommendations is really that in chordomas, where we have doubtful surgical margins or concern about the surgical margins, whether or recurrent sarcomas, there's a strong recommendation to use adjuvant radiotherapy, whereas in primary resection that recommendation is weak if we get clear tumor margins, and the same is in the case when surgery is actually not feasible. Then, of course, we have no other option but to do radiotherapy. A similar picture than what we saw for the chordomas, we see for the chondrosarcomas. Now, a chondrosarcoma is a bit different type of tumor. It's a different beast in terms of that it's not necessarily amenable to many other therapies. There's no chemotherapy that can reliably control the tumor, and it doesn't respond to radiotherapy as well as, for example, a chordoma would. But the picture that we see here is quite similar to what we've seen with the chordoma. This is again is data from the AO Spine Tumor Knowledge Forum, also showing that yes, it reduces the local recurrence significantly, but didn't have as much of an effect on the survival if we are NK appropriate, so have clear tumor margins, or do not have clear tumor margins. That would also then mean if we do unblock resection or an intralesional resection. So the challenges that we're facing is really that the first chance is the most important, and in many cases it is the only chance to at least potentially cure the patients. Yes, there is a recurrence rate, and but that initial operation is really the most important one. And we've seen this also in patients that we had to do that we had to operate or were referred once they had a recurrence. Dealing with that recurrence is much more difficult, and in the case of the chordoma, for example, it is actually quite a horrible course. Anecdotally, I once operated on a patient that had for a so-called metastasis of unknown origin. And whenever you have a metastasis of unknown origin in the spine, you need to do a biopsy and really rule out the primary malignancy of the spine. In many cases, it could be a chordoma, because chordoma is a bit of a chameleon and can present in many different ways. And so chordoma there was considered also by the pathologist. It was a test for brachyury was done, which was negative, and it was concluded that it was an adenocarcinoma of unknown origin. I did an intralesional resection, reconstructed with a cage, and then 2 years later the patient came back with a recurrence, at which point we were still surprised that she was still around, because according to the prognosis back then, the prognosis wasn't that good, and we did then another histology after the imaging, and then all of a sudden the brachyury test was positive. So we knew now that we were dealing with a chordoma, and it wasn't an adenocarcinoma of unknown origin. And as it happens, the metastasis then was along the axis. I did a lateral axis to do a lateral resection of the L3 vertebral body. The tumor metastasis was along the approach there, around the nerve roots, and the patient was in terrible pain. We did several revision surgeries or two revision surgeries on her, which could not touch her pain. So in those cases, the recurrence is horrible, leaving the patient in a very dire state with lots of pain that cannot be treated in any other way and reliably. So that brings me to treating a patient without an appropriate diagnosis and staging could really lead a potentially curable or controllable disease to incurable, with in some cases really devastating effects on long-term consequences for the patient. We certainly have to consider the anatomical variety and the location of the tumor, how it touches other structures, particularly the neural structures, and then discuss whether we can do a purposeful sacrifice of the nerve roots, meaning does the en bloc resection, or does it justify the sacrifice of the nerve root in terms of the prognosis? Is the tumor really resectable in a reliable way? Because these are challenging resections, but also reconstructions. And we always need to keep in mind, even if we do a fancy surgery, if at one spot we breach the tumor, then the prognosis may not be better than if we had done an intralesional resection from the start. So our approach has always been to get an appropriate diagnosis and treatment decision in conjunction with the sarcoma board. So all cases are presented and discussed in the sarcoma board in a interdisciplinary or multidisciplinary manner to then come to a conclusion what the best treatment for that specific patient is, and really elaborate the whole treatment concept that may or may not include neo or adjuvant therapy depending on the tumor type. It is a team approach that includes anesthetic intensive care. It also includes blood management. Some of these tumors, especially the total sacrectomies, can be very challenging, especially if they had, for example, neoadjuvant chemotherapy, such as, for example, in an osteosarcoma. Then the surgery is long, and because of the scarring, and one loses lots of blood. So we need proactive blood management from the anesthetic side to compensate for this. Only this way we can operate for 10 hours. Then our concept has been that we're two operating surgeons. That allows us to take a break if it's a 10-hour course. It also allows the other one to kind of slow down a bit and to take a bit of a mental break while still being physically there. While on the other side we continue, I or my colleague continued with the operation. Then in some cases staged surgeries make sense, while in many cases we are able to resect them just only via posterior. The total sacrectomies, we've learned the staged surgeries in our hands worked better. Or for example, if we do posterior resections, if they affect the thoracolumbar junction where the diaphragm has insertions, then it may be easier to do an anterior release and release the cross and everything than for the posterior resection. We'd like to do nerve sparing if it is oncologically feasible. Of course, if the nerve is completely encased in the tumor, then we have to sacrifice it. But if it's stuck to tumor capsule, even though it is difficult to reach, then we try to find a strategy to preserve the nerve root. And then the collaboration with plastic surgery is very important, as those resections usually leave a very big void that in some cases, for example, the sacrectomies need to be covered. And we've also had very good experience with bone reconstruction then with a vascularized fibula with usually good union. So the classic resection is the spondylectomy as it has been described in 1997 by Tamita et al. This requires, however, that the pedicles are cut, and in many cases of extra compartmental tumors, which you've seen in the chart before, that would mean that we breach tumors. Some people accept this. They do a planned breach of tumor in order to be able to use this technique. We've usually tried to find a tumor-free corridor. And then what's important is that we get essentially a circumferential exposure of the spine and the tumor. That looks pretty straightforward here when you only have maybe tumor inside, or if you do a vertebral column resection for a spinal deformity. However, if a big tumor is sticking out here, then all of a sudden that circumferential exposure, getting the vessels, mobilizing the vessels from the back while not being able to see anything because of that large tumor mass, becomes a lot more challenging than what is shown here. And that's an illustration here after such a circumferential exposure, complete resection of essentially off the spine at that level. There's no more spine left at that level. That was, I think, T5. And then reconstructions with a cage. It is quite normal that we see the lungs, etc. So we just need to put chest drains then at the end of the surgery. So when is an en bloc resection now feasible? Well, I mean, one of the criteria is clearly that we need to have somewhere a tumor-free corridor, as for example here, where we know, okay, here we're gonna, if we cut into the lamina here or here, we would definitely breach the tumor. So we can essentially deliver the spinal cord only through that tumor-free corridor. Because if that's not possible, if we still wanted to consider en bloc resection, it would essentially mean then spinal cord amputation or amputation of whatever neural structure that is involved, for example, in the lumbar spine or the sacrum. Then we need to have ideally compartmental lesions, or we should have a dissection along the tumor capsule has to be possible, which sometimes is not possible, particularly in high-grade tumors. If the histology comes back as a particularly high-grade tumor, then one can put the question mark on this. In those cases, we've also seen an anterior approach, for example, a thoracoscopic approach may be useful, because then we'd already know if there were strong adhesions to the tumor capsule, and maybe in this case then an en bloc resection is not feasible anymore. So that's an example here of an aneurysmal bone cyst. What I would like to illustrate here is how we plan here the tumor corridor. The bone cyst was on this, it's a benign tumor, but it is locally invasive, and here we found that en bloc resection was clearly feasible and probably would get us better tumor control in the long term, and that's why we chose to do an en bloc resection. And the tumor-free corridor was essentially this part of the lamina here. If we had gone more medial, then we would have breached into the tumor, which you can see here. And then we plan to do a cut here, and also cut off the ribs, then to deliver this to remove the tumor en bloc. And that's what this looks like intraoperatively. And the challenging part is not only that sometimes the corridor to deliver the spinal cord is actually quite narrow. What is often quite challenging is actually that we need to ligate the nerve roots over the top on the other side to be able to deliver the spinal cord through this narrow corridor. Sometimes you have a bit of wiggle room because if the tumor is not so solid, but one should certainly avoid breaking the capsule or breaking even the specimen in half by trying to deliver the cord. So those are some of the challenges that we're facing. This is after resection. That's what it looked like with the split of the vertebral body. But then in order to be able to fit the cage and adequate bone graft, we still had to sadly resect the whole thing and then reconstruct it here with a cage. At this point, and I mentioned the role of vascularized fibula and the vascularized bone graft to bridge that large defect. Here we just put in local bone graft because we thought we had adequate bone graft from resecting the healthy vertebral bodies, but that didn't result into a good fusion and resulted into subsidence of the cage. And then the 14-year-old patient was about a year later or so, then had to undergo another reconstruction here then with 2 fibula, which then healed in the later course. This is another case of an osteoblastoma, C71, also again potentially a benign tumor, but because of its size and of its location, we decided that maybe we felt that an en bloc resection is feasible, and because of its size and because of its invasiveness, it was then decided in the sarcoma board that if we can, we should maybe consider an en bloc resection, and this is what we've done here. That was the planning. We started in this case with an anterior approach to mobilize everything, the tumor from the front, and already make then a cut where we would like to then separate the tumor from the rest of the spine with parts of the vertebral body involved from the front, which can then be completed from the back. Now, what we've learned over the years is that we should always try to max out what we can do from one side. So usually saying, well, it should be fine, we can do the rest then when we go from the back, or vice versa, is not a really good strategy, because then all of a sudden when we are actually then on the other side, you know, often we think, well, we should have done that. So in general, it's best to do as much as we can to then make life easier once we're on the other side. Here, the posterior approach, where we then had to take the lamina off to deliver the cord through that tumor-free corridor, dissect out the tumor, cut the rib, and then essentially complete that cut from the back. If it wasn't completed already, we like to do this with a bone scalpel. Sometimes the blade of the bone scalpel is not long enough, and then we have to complete the cut from the other side, and then deliver the tumor and essentially roll it out. That often means that we have to, here we were essentially C71, we were essentially almost in the chest cavity, as we had to take 2 ribs to deliver the tumor, and that's the reconstruction afterwards. Now, what's interesting is that this case then came back as a low-grade sarcoma. So we had, what I didn't tell you before, is we had to I think we had to sacrifice a C7 nerve root, which of course rendered the patient with some weakness. But given the fact that it then came back with a low-grade sarcoma, the patient very much accepted this and was very happy that we actually then did consider an en-bloc resection. This is a C2 chordoma here, very challenging location. Involving C2 going down to C3, sparing the vertebral arteries on both sides. And planning here involved several cuts. Actually, you can see that best here. Planning involved a cut that actually went through the tip here, as you can see the cut, and with lateral cuts in the tumor-free margin, such that we then essentially almost could treat it as a corpectomy. As you can imagine, doing these cuts, especially the one here from the back then to the front out to the arch, wasn't exactly an easy cut to do, and then the tumor could be delivered from the front. The reconstruction here entailed iliac crest bone graft that was then put here between the lateral masses and the joints and secured here with the instrumentation with a screw. Why was an anterior cage not used? Well, there are cages with a flange that one can sit on, for example, the C1 arch, or in some cases even on the clivus. In this case, that wasn't an option, because those cages only come in titanium, and because the patient was supposed to be sent for adjuvant proton therapy, we couldn't use a titanium cage. So that's why it was left empty, and we relied on the posterior instrumentation and the bone graft in the back. And that's the image, I don't know how much after, must be about a year after or something like that. This is also, again, a cervical spine tumor, chondrosarcoma C5, a challenging case. Florian knows this case, he's seen it before, where the vertebral artery on one side was involved. And planning here involved a balloon occlusion test of the contralateral vertebral artery to give us peace of mind that we actually can resect the vertebral artery on the other side. The patient already had a pathologic fracture, so he was a bit query whether we can actually resect the tumor en bloc. We then did a first stage from the back, where we isolated, where we already ligated the vertebral artery on the side where we want to resect it, and freed up the vertebral artery on the contralateral side, such that we can then deliver the tumor from the front, which we then did in a second stage. This is the specimen, and that's the view from the front, where you see the spinal cord here, you see the rod in the back, so you can essentially one can basically see through the spine, with the C5, C6 nerve roots ligated and the C7 nerve root here intact. And then we reconstructed this with a cage and put the fibula next to it, as here that is secured with plates. This patient had a very good long-term follow-up with and this is the postoperative X-ray. He also had then because of the C5 and C6 nerve roots, which were sacrificed, he then had a reconstruction with a nerve transfer done by plastic surgery, and he almost regained full shoulder function. He sent a picture of a shelf to my colleague that he put up, showing that he can clearly do work over shoulder level with both of his upper extremities. Then changing anatomic region here, another very challenging case are the sacral chordomas. Sometimes they're quite advanced here, breaching into the sacroiliac joint on the right side, going up into the tumor, into the L5S1 frame, into the joint. The question there is, of course, what can we preserve? Can we preserve the L5 nerve root on the right side, or do we have to resect it with the foramen, or can we resect just the superior articular process of S1, leave the foramen intact, and then isolate the L5 nerve root over the tumor? Can we preserve the S2 nerve roots? And the S1 right is clearly in the tumor, as you can see in the MRI, and that had to be sacrificed. And this really matters because from earlier works we know that depending on what nerve roots we can spare, that has a huge impact on motor, bladder, and bowel function. So as soon as we get above the S2 level, then we have a very significant deterioration in bladder function, certainly with S1 and above, in terms of motor function as well. When the S1 and sometimes the L5 nerve roots are sacrificed. In order to access this, we have to essentially access the sacroiliac joint from the front. We do this in two stages. First with an anterior stage, in most cases transperitoneal approach. Sacrifice the nerve roots that we already know we need to sacrifice, so separate them from the lumbosacral plexus. Do the osteotomy cuts and release the discs if we need to split the discs. In some cases, when we cannot resect or spare the L5 nerve root, we need to resect the foramen, and then we need to go up and to the L5 disc and split the L5 vertebral body from the front to be able then to deliver the tumor en bloc. The cuts lateral to the SI joints are usually the plane that we look for is between the psoas and the vessels. If we go down there, then that's usually where we find the SI joint and can make then the lateral cuts from this. And this is usually done together with the general surgeon because they need to do a stoma. Such we then to then allow for the resection that helps us with care, that helps with initial continence, and this can be then reconnected. The stoma can be reverted should the patient then still have sphincter function after the resection. The posterior exposure then essentially allows then to deliver the tumor. We need to complete all the cuts that we do from the back, ligate the nerve roots that we have to do a transverse cut at the upper level, wherever the resection level is. That may be the L5S1 disc. In some cases it is only half of the L4-5 disc, for example, in this case where if we would like to, or if we have to sacrifice the L5 nerve roots. And that is what the specimen looks like here. This was a tumor that was delivered. SI joints were both involved. This is what the reconstruction looks like. A small detail here is the mesh that we have to put in, because as you can imagine, there is no more barrier between the posterior aspect of the body and the bowels and the peritoneal space. So I've had cases where I went back with the plastic surgeon and to do the fibula reconstruction here, where we then found that actually bowel was almost wrapped around the dural sac. So that's when we then started to use meshes and fix them with either sutures or even anchors into the remaining iliac bone. That's what the reconstruction looks like, a fibula that is separated, and sometimes one can make this triangle then to reconstruct the continuity between the spine and the pelvis over this instrumentation here. And that's what the flap insert then looks like. It also helps cover the dead space and helps, of course, then with wound care. The fact that we have a stoma also helps greatly with wound care because we don't get any contamination then of that wound with feces. And sometimes the reconstructions are quite creative, and it was actually the plastic surgeon's idea to do this. This was a hindquarter amputation that we had to do, and because we could spare and had almost a healthy leg, we kept the vasculature and the femur and used the distal femur then to essentially reconstruct the ischium such that the patient has again something to sit on. And that was the fixation that we did, because that only went to one part of the iliac wing, because here it was missing. We then had to come up with a fixation, and those are actually pedicle screws in a femur, and that's what it looks like, which allowed the patient then to have a better sitting balance, as if there was no bone left, because then sitting becomes a big problem. So in conclusion, I think we stop here. Those are really rare and challenging procedures. En bloc resections, in general, although they are challenging and laborious procedures, result in better local tumor control and potentially high rate of survival in the most commonly primary tumors of the spine than any type of intralesional resection. So although they're technically challenging, en bloc resection at the moment is still the gold standard until we have something that can either control biology better, or we clearly can show that radiotherapy can achieve the same local tumor control and potentially survival at a much lower morbidity, maybe together only with debulking. But for the time being, in all malignant primary tumors, we really have to get it right the first time. Thank you for your attention, and I think we'll take questions now.
Yes, thank you, Dominic, for this comprehensive overview on the complex surgical treatment of primary spinal tumors. So for all participants of the webinar, if you have a question, please use the Q&A box or the chat, and we will discuss your questions, your coming questions then. I'd like to start with a question regarding the point of neurological deficit prior to surgery and identifying a primary tumor, which is always a problem.
Yes.
As we tend to be driven by neurological deficits, like in an emergency bay, operating this, doing quick surgery for neurological deficit. And I think it's for cases you do not operate, it's hard, where you suspect a primary tumor, it's hard to justify whether it's a primary tumor or not. So how do you handle those cases? Which one is the most suspicious one for a primary tumor? And as we do know for Ewing sarcoma, that the patient with a Ewing sarcoma and the neurodeficit can recover quite well under chemotherapy without touching this tumor, which is from an oncological standpoint superior and neurologically justified.
Yeah. Exactly, it was the best outcome. Well, I mean, that's an excellent point, and this is really, a clinical dilemma that we're facing quite often, and we've had this on occasions, and it usually also causes quite a bit of anxiety and unease within the team, because it is very clear if the patient comes in and has, say, a mild or an already established neurologic deficit, which at this point is stable, we suspect a primary tumor or already have the diagnosis of a primary tumor. In most cases, we don't already have the diagnosis of the primary tumor, but we suspect it. Then we have always urged the team to wait and not intervene at this point if the neurologic deficit is stable. If there's core compression and no neurologic deficit at this point, the patient, however, still has an emergency admission. The on-call surgeon is getting nervous, is like, well, what do I do with this when this happens? Well, then what we've done is we've identified, we said, for example, look, here you have a safe corridor. You can take this much bone of the lamina away. And should the patient deteriorate neurologically or have an evolving neurologic deficit that we cannot wait any longer on, then you can decompress as much as here. That's how you can do. And in very many cases, this is actually sufficient. So we then decompress the cord and don't burn any bridges to still allow for an en-bloc resection. There's a caveat to this, though, is, sometimes depending on how much invasion there is in the spinal cord, the cord could be quite under pressure. And then only making a small window is not advisable. Then you have to go and do a much longer laminectomy, also in the tumor-free areas, to then allow the cord to drift back, because otherwise it just drifts back in one area and is impinged then against the intact lamina, and that we've seen a case of this that then caused a neurologic deficit. So that's a point to consider. But it's a clinical decision-making dilemma, and it takes a bit of experience to then say, no, let's sit tight, and because the reflex is neurology, we need to go back in and decompress the cord right away, right? So, but that may not always be in the best interest of the patient.
I think this is a very important point, the recommendation to decompress in a part which is not tumor carrying, to get released in a patient which is still still has the suspicion of carrying a primary tumor. And
if the tumor is circumferential, then en-bloc resections as such is not possible anyways, depending, and then one can also intervene on an urgent basis.
Okay, so concerning biopsies of those tumors and the histology, on how do you usually get biopsies of these tumors? Is it CT guided biopsies? Do you do shielded trocar, and how do you deal with the biopsy trajectories? Do you still excise those trajectories, or is it no longer necessary when using a shielded trocar?
No, we entirely rely on the interventional radiologists to do that. They're I guess in most cases CT guided, and no, we do not. We do not necessarily mark or resect the site of or the trajectory of the biopsy. And given the follow-ups that we have, and in Oxford we've had follow-ups over 10 years, this has not, I think it's still done in limb orthopedics. They still very much try to resect the trajectory, but don't hold me to it. I would have to ask them. But in the spine, no, we've not actually paid any special attention to that.
Okay. Now we have some questions. Now the first one is about pediatric cases. Is there any difference in pediatric cases in the surgical approaches, prevalence and prognosis of those primary tumors?
Well, that depends on the tumor type. The kids present with different types of tumors, right? So, it very much depends. I remember one case where, I don't remember what type of tumor it was. But in order to be able to do such an en-bloc resection, you need to have some sort of a solid tumor. The ideal is a chondrosarcoma, which is usually quite a hard tumor. But if the tumor is relatively soft, which was the case in this pediatric tumor, then and invading the canal, then an en-bloc resection is not possible, because you will not get that plane. The tumor will, as soon as you're there, it will fall apart. So in these cases, we do not attempt en-bloc resections. Okay. Not in that way.
Now we have a question from Switzerland, from Enrico Tessitore. He's asking about your opinion about carbon cages, Icotec cages, or the option of customized cages made for the individual patients.
Yeah. So in Oxford, in the past years, we have started using custom-made carbon implants. That's just to facilitate adjuvant proton or carbon therapy. That clearly has a role also for monitoring any potential, let's hope not recurrence. Yeah. So for disease monitoring, that's much better. So yeah, they those type of radiolucent implants clearly have a role. Also with the screws, the handling, of course, especially to an orthopedic surgeon, when we're used to bend rods and titanium, is clearly very different and requires a bit getting used to.
Okay. Now we have a question regarding, I think it's regarding the case of the C2 chordoma. If you would place a cage in this case, how would you approach it, or proceed the question? How did you get to C2? Did you do a transcervical from below? Did you do a transoral in this case? Cutting
no transoral, no.
You had to cut these.
Many cuts. The tip was done from posterior, essentially with a very oblique trajectory to the cord. The target point was the mid of the C1 arch that we could see in X-ray, and then direct the bone scalpel blade and to that area. We also knew that this is according to the CT. There was a bit of an osteolysis, which caused a bit of we were not certain at some point whether we may have breached a tumor there, because there was an osteolysis, but that was just the natural structure of the bone of the odontoid peg in this case, whereas the MRI then clearly shows that actually tumor finishes below. So the target point was the C1 arch, the midpoint of the C1 arch, because that way we knew that we're going to be clear of tumor, and then made an oblique cut through that, which you can approach from both sides, then from posterior. So that cut wasn't done from the front, that was done from the back.
So that means you did the most superior cut from the back, cutting away the tip of the odontoid tip, plus putting in half in the C1 arch, and then you went from cervical below, doing the lateral cuts and the inferior cut. Yeah,
complete lateral cuts. They were also done from the front, from the back already.
Okay, and you did go transcervical.
Complete. And you join them up essentially. Yeah. Sometimes you don't find them right away, but that's why that nice CT scan, because that's something that we always did is when we had two stages like this, we like to have CT scans between the two stages, because you could precisely see where the cuts were made, and that's why it's also why we can demonstrate it like that. Right.
Okay, well, we have a question from Andreas Dimitradis. He says, can you comment on timing of organizing a case from time of presentation, potential of metastatic compression, chondrosarcoma versus chordoma, and the need to get a multidisciplinary team? What would you advocate as a good time window to plan surgery in chordoma versus chondrosarcoma?
Well, I mean, it's a very long question. I'm not sure.
Timing of surgery. How much? What do you think?
Well, chordoma and chondrosarcoma are slow-growing tumors, right? And given all the workup that's needed, given the timelines, also when I was still working in the NHS. We plan those, not like you're somewhere on a waiting list and you have your surgery whenever it's your turn. We plan those in as soon as we can, but if they're neurologically stable, we don't need to rush it. We have time to do a proper workup, a proper discussion, get the team aligned. If the plastic surgeon, if the general surgeon needs to, find a date, weeks, months down the line. Again, they're slow-growing tumors. If there's no imminent neurologic or evolving neurologic deficit, then we have that time.
Then we have a question regarding predictors. I would call it predictors of functional outcome and overall oncological outcome. And I think you mentioned the most important predictor of oncological outcome, which is anakin-appropriate versus inappropriate resection of those tumors. But are there further aspects of, let's say, the tumor growth, patient cofactors, which are very relevant for the functional outcome, which is of course level, height, and the nerve roots sacrifice, and for the prognosis of patients? Is there anything else?
Well, I mean, it's such a mixed bag you know, like no tumor is like the other, right? When it depends on the location, on the extension of the tumor, what structures they involve, and that then governs the outcome. Generally, the bigger and the closer to any vital structures, or when it's encasing nerve roots, etc., then you know the surgeries are longer, the morbidity is higher, and the functional outcome may be less. But you know, like even if we had patients that you know were not paralyzed during surgery, but then, for example, had a problem with a flap or so, which then resulted, unfortunately, into paralysis. And you know, even so, you know, when it was oncologically, when the surgery was, when we had clear margins and that was communicated to the patient, you know, they accepted that. They accepted this morbidity, given the underlying disease. Certainly, you know, if we in the future have an alternative, such that we can operate, do smaller surgeries with less morbidity, and treat them with adjuvant radiotherapy or biological treatment, that you know that would be preferable. Yeah, but it's I mean, it's really the structures that is close to whatever we have to sacrifice, and then the oncologic prognosis versus the morbidity of the resection then governs whether we actually should consider it or not. And in some cases, you know, in elderly patients, we know that oncologically, anatomically, the right thing to do would be an en-bloc resection, but the patient is just not fit to tolerate that amount of surgery. That was also the case. And it's sometimes difficult if they have neural compression, if they have pain, then to tell them, no, you should just go for radiotherapy, for example. Yeah.
Okay, good. Thank you, Dominic. Excellent presentation, excellent discussion. I'm thinking many
Thank you very much
important things
for having me.
Covered and clarified. Now, thanks for this time. Now, our next webinar for the spine section will be November 2nd. The topic needs to be defined and will be announced in advance to the webinar, of course. Whenever you as the audience have any special topic you would like to have a webinar now, please send me an email, and we'll consider your wishes, your suggestions of topic for further webinars. So for today, once again, thank you. Enjoy the rest of the evening to you, Dominic, and everything else listening.
Thank you.
And see you next time, beginning of November. Thanks a lot. Bye-bye.
See you in Belgrade.
Yeah, see you in Belgrade first, of course. Sorry.